Hi, I'm John Cooke. I'm professor and chair of the Department of Cardiovascular Sciences here at Houston Methodist Hospital. I'd like to tell you about a paper we recently published in Circulation that's going to change the conceptual framework regarding heart failure recovery. What we have found, what we've discovered is that heart failure recovery is in part microvascular recovery. So here at Methodist, we have a very active heart failure program. We see a lot of patients with severe heart failure, and some patients are so severely affected by their heart failure that they need help. We put in a left ventricular assist device. This is a pump that supports the heart, that provides some support for cardiac output. The way this is done surgically is that the conduit is put into the apex of the heart. So we take a small part of the heart out and put the pump in, and then the tubing goes into the aorta. That conduit goes into the aorta. The pump is within that conduit and pumps about 4 liters per minute. And that's enough for that patient to survive and do better. And over that period of time, 6 months to 2 years or so, they become eligible for a heart transplant. And at that point in time, the pump is taken out and the heart is taken out, and the patient gets their heart transplant. Now, one thing that we've observed in patients that have a left ventricular assist device in, some patients get so much better, they don't need a heart transplant with that left ventricular assist device in. When we take it out, they don't need a heart transplant. And many of the patients improve somewhat. They still need a heart transplant, but they improve somewhat. And we wondered, what is responsible for this improvement in the heart with the left ventricular assist device in? So the tissue that we take out, we began to examine. And what we found is that in patients with severe heart failure, and these are primarily patients with, quote, non-ischemic heart failure, they don't have coronary artery disease, but they have microvascular disease. They have reduced capillary density, and they have a lot of this fibrosis, this blue that you see in the figure, that's fibrosis. Now, the interesting thing that occurs after 6 to 12 months of having a left ventricular assist device in, that fibrosis, much of it diminishes, and there's an increase in capillaries, the small vessels that supply nutrition to the heart. So we wondered, what is the mechanism behind this interesting change in the heart with the left ventricular assist device in? We have a preclinical model of heart failure that we can study. And in this preclinical model, here's a normal heart. This is normal. You can see a nice muscle, cardiac muscle, and this is a stain, a fluorescent stain for the capillaries. And you can see a nice network of capillaries that are perfusing that heart. When we give drugs to induce heart failure in this model, we see, so this is heart failure. We see the heart is failing. We see this fibrosis again. You saw that in the last picture. And we see a reduction in the microvessels. So that network of vessels that are supplying the heart with blood is diminished. But when we withdraw the drugs that are causing the heart failure, and then the heart muscle improves and the microvasculature expands. So we're interested to understand what's responsible for this expansion of the microvasculature and the improved perfusion to the heart and the recovery from heart failure. What we've seen so far in the patients and in the preclinical model is we've seen that with recovery from heart failure, there's a reduction in fibrosis and an increase in the microvasculature. So we had a hypothesis. Is it possible that the fibroblasts that are causing that scar, is it possible that they're transdifferentiating into endothelial cells? They're becoming endothelial cells and contributing to the expansion of the microvasculature. That was our hypothesis. We had reason to believe that might be true. So in our preclinical model, we can actually track what's happening to the fibroblasts. We can track using what's called flow cytometry. And here we're seeing the fibroblasts. We're able to identify the fibroblasts in one of those hearts that I was showing you. This is a normal heart. We're just seeing fibroblasts. We don't see any fibroblasts that have turned into endothelial cells. And by contrast, when we look at the preclinical model during recovery from heart failure, again, we see fibroblasts. These are fibroblasts. But we also see fibroblasts that have become endothelial cells, vascular cells. Here, a lot of them. So our hypothesis now is that indeed the fibroblasts have this capacity to become vascular cells and contribute to re-expansion of the microvasculature and improve perfusion of the heart. We see this in the human hearts as well. And now this is a lot of computational biology that I won't go into now, but basically we have ways of tracking what's happening to vascular cells and fibroblasts in the human heart. This picture is from a patient with a failing heart. And here we're seeing vascular cells, endothelial cells, transdifferentiating into fibroblasts, scar cells. By contrast, in the recovering heart, we're seeing a reversal of that process. We see fibroblasts becoming endothelial cells. So this supports the idea that the recovery from heart failure is a microvascular recovery. The scar is turning back into microvasculature and perfusing the heart. So to conclude, in a patient that is developing heart failure, they have hypertension or they have diabetes. That is a cardiac insult. It's driving vascular cells to become scar cells. Fibroblasts are scar cells, and you get this increase in fibrosis that makes the heart stiff. And you get a reduction in the vascular density that impairs perfusion to the heart. That causes reduced cardiac function and heart failure. Now, the cool thing is that this is all reversible because we now have shown that when the LVAD is implanted, that reverses a lot of the cardiac insult because now the pump is supporting the heart. And now we see fibroblasts changing back to endothelial cells, and that reduces fibrosis and increases vascular density. It improves perfusion to the heart, and the heart begins to improve. And that is why our patients with a pump in start to get better. Some get so much better that they don't need a heart transplant. Understanding this mechanism is going to allow us to enhance it, modulate it therapeutically, so that we can take advantage of this natural mechanism to reverse heart failure and improve the care of our patients here at Houston Methodist Hospital.